All right. Good morning. Happy Monday. Last skills day. This is it. Easy day, really easy day, because almost everything we're going to learn is a rehash of something else that we've learned, with one exception, but that skill isn't too hard. You had over the weekend chapters 8 and 9. 8 was on nutrition, 9 was on rehabilitation. Do you guys have any questions on what you missed? Any questions? No? Okay. Jake, can you plug in the iPad? Here's the cord. Okay, when assisting a visually impaired patient to walk, is that the one you're talking about? Okay, when assisting a visually impaired patient walk, A, walk behind the patient. B, give information on corners and steps as you approach. C, only walk to the nurse's station and back. Or D, lead by pulling on the gait belt. So let's look at each one of those individually. I want to start at the bottom and work our way up. We never pull on the gait belt. That's kind of like a leash on a dog. You wouldn't do that. So the gait belt is used to give them our strength, not to lead them somewhere. C was only walk to the nurse's station and back. Where do we go for information on how far to walk? Care plan. B was give information on corners or steps as you approach. Well, if somebody is visually impaired, if they can't really see well of the dangers that are coming to them, like steps or navigation, we have to turn to the right or turn to the left. They're not going to know that those things exist because their visual cues aren't going to let them know that. So we, in a very real sense, become their eyes. So when we're helping somebody who has any sort of visual impairment walk, our job is to notify them of things that are in the way, of navigational difficulties. There's a curb here. We're going to step up. We're going to basically tell them what we are seeing so they can navigate it safely. And then A is walk behind the patient. Well, if you're walking behind the patient and letting them lead, that's problematic because they're not going to know of the dangers that they're encountering. Does that make sense? So talking them through it is really the right answer here. This is what we want to do when we're helping somebody who's visually impaired. Any others? Any others? Okay, let me go ahead and get your scores. All right, Delilah. Thank you. Jenny. Thank you. Isaac. Isaac, can I get 5, 6, and 7 from you? Okay. Thank you. Fermana. Thank you. Kaylee. Kaylee, can I get 5, 6, and 7 as well, if you have it? It'll be 185. If you don't have it, it's no big deal. I'll come back to you on Wednesday. Okay, that's fine. Diana, Naomi, Andrea, Sarah. Thank you. Sarah, can I get 7 from you? Thank you. Daisy, can I get 7 from you? Thank you. Teresa. Thank you. Christian. Faith. Okay. Faith, can I get 5, 6, and 7? If you've got them. If you don't have them, I can get them from you next time. Okay. Thank you. All right. Any questions? Questions? One class left, guys. Today is last skills day. On Wednesday, we're going to be going over some very important information on what's going to happen after your certification. We're going to talk about renewal requirements, continuing education. What is it? What do I have to do? Am I ever going to have to take the test again? How do I renew? Where do I renew? Does it cost money to renew? I mean, all of those questions. We're also going to talk a little bit about finding a job in healthcare, bless you, because it's different than finding a job in other industries. And a lot of people don't understand the differences. So I'm going to explain them, tell you how to maximize your job search so you have the best results. Okay. We will also have some practice time in class on Wednesday. We'll have practice time today as well. And we're going to take a class photo as well that I put up on social media. I don't tag anybody, so you have to go to my social media and share it yourself. That way, anybody that's in the witness protection program, you know. Please make sure you are in your t-shirts for Wednesday. You will be returning the yellow book on Wednesday. So bring that back to class with you. Remember that we have the test and care plan sets. This is the last week, so I'm going to remind you of everything that you have access to at a discounted rate through Wednesday, because after Wednesday, the price goes up for you guys. Game show tomorrow at 11 a.m. Eastern on my YouTube channel. It's the only place you can see the game show. Tomorrow, we're doing follow the care plan questions. So I'll give you 15 questions and you can answer them live in the chat. You simply put your number of the answer you want to choose in the chat, hit send. Program that I use reads the answers, the order they come into YouTube, awards points, puts you on a leaderboard. Top 3 people get prizes. So we got some really cute t-shirt options that I'll be debuting tomorrow. So you could win yourself a free t-shirt. If you have not gotten your CPR yet, now's the time to start thinking about it. You don't need it for the class. You don't need it for the test. You will need it to work. Julie gives you a discount. It's right here in this class. This is her classroom. She'll give you a discount for CPR and first aid through her. And if you have not taken the workplace personality quiz, now is the time. Now is the time. This will give you a good idea of where you should start looking for employment in healthcare based on your personality and your constraints. So as far as shifts and holidays and hours and how much you want to advance and learn, those types of things. So this is free. If you have not done this, I would really strongly suggest you do so before Wednesday. It'll take you 5 minutes, but then what I'm talking about on Wednesday will make more sense to you. Anybody take this yet? What'd you get?
Either nursing home, but then I retook it and changed a couple of things and it said a hospital.
Oh, okay. All right. So do you see how your answers can change your location?
You have to have more of an available schedule where you're open to anything to work with a hospital.
Yep. Yep. What'd you get? Pediatrics. Very good. So we have Tender Care right down the road behind Friendlies. They hire our students. You don't have to be certified to work in that setting. So if pediatrics is something that you're interested in, go pay them a visit. Okay. How do we know what to do with each patient? Care plan. Yeah. Every skill starts with an opening. Every opening starts with a knock. How do we know when we need gloves? Non-intact skin. body fluids, and personal skin, anything normally covered by a bathing suit. If you're going to use supplies, you need a clean place to put them. So we're going to use a barrier. Privacy blanket is used anytime a patient is uncovered or undressed. That's right. Linen rolls. Nothing can touch the floor except feet, right? Nothing goes on the floor. Patients should always be where in the bed? In the middle of the bed. Anytime we get water, we check it and patient checks it. Basin cleaning, rinse it, dry it, store it. Shoe rules. How do we know a gait belt is tight enough? 4 fingers. And during the closing, the bed must be in what position? The lowest position. Pulse normal is 60 to 100. Don't use your thumb. Dressing a resident, undress strong arm first, dress weak arm first. Hand and nail care, wash, rinse, dry, clean under the nails, file them, lotion. Making an occupied bed, don't let them lay on a bare mattress. Make the bed a half at a time. Side lying position, it's all about where they are after the turn. Where should they be after the turn? Center of the bed, pillow behind the back, one between the legs, one under the upper arm, and adjust the one under the neck. Foot care is all about inspecting. Take a look at that foot. Mouth care, brush their teeth. Don't overthink it. But what position do they need to be in? Sitting position. Respirations, we don't tell them that we're counting their respirations. Range of motion, we do these to retain function. Remember, we're not trying to make anything better. So if the patient says, ow, we stop. Go below the ow, let the nurse know. Denture care, 2 parts. We're going to clean the dentures and the mouth they came out of. I saw a comment on one of my videos this weekend about denture care. And I don't normally respond to comments on social media. I just let them go. If I would be there all day. We get hundreds of comments. But this one, actually, I'm sorry, this was on my YouTube video, but this one kind of made me laugh a little bit. The person said, we use denture paste when we clean dentures because toothpaste is abrasive. Guys, do not use denture paste to clean dentures. Denture paste holds the dentures in. Okay, you're just smearing super glue all over your dentures. Don't do that, right? If the care plan calls for the fizzy tablets, that's fine. If they call for toothpaste, that's fine. Do not use denture paste to clean dentures, though. Denture paste holds them in. So I kind of found that one a little bit. Somebody out there is teaching denture paste for dentures. Don't do that. Okay. Ambulate with a gait belt. We're going to walk slightly behind and to one side so we can watch the patient. We're going to let them lead at their own pace. We'll hold on the gait belt in the back so that if they start to get wobbly, we can help guide them to the floor. This is not to catch them. We do not catch a falling patient. We guide them to the floor, but we don't try to hold their weight up and keep them from going to the floor. Okay, do not catch a falling patient. Partial bed bath. Face to waist, front and back, face first, no soap. Apply all the rules we know. Transfer, make sure that wheelchair is close. It should be locked when you're putting a patient in and taking them out and when you leave the patient. So unless it's physically moving, it should be locked. That's a safety issue. Feeding a patient, safety and socialization count here. So have a seat, strike up a conversation, feed them slow, and encourage their intake. Pericare, we're going to wipe away from the urethra, top to bottom, move away, fold your leaf. You should never use the same leaf on 2 body parts when we're washing a wet body opening. Good? Good? Okay, now we're on to bedpan. Today's all about toileting. So today we're going to start with bedpan. So if you go to page 147, you can see all the principles here that apply to this particular, apply to this particular skill. They're all spelled out for us here. Down here is our test-specific information. Somebody with your level of experience, which is none, should be able to help a patient with a bedpan in 10 minutes. That's way more time than you need for a bedpan, guys. Way more time than you need. That person that you're going to be helping is a live student. So let me time out here and explain this. Because people get really nervous when they see that. Wait a minute. During the test, if you are a patient for this skill, you are staying fully clothed. You are not removing anything. You're not going in a bedpan. We're going to put a patient gown on over your clothing. Okay, over your clothing. You're not going in the bedpan, but somebody will put a bedpan under you and they will take the bedpan out. They're not going to try to clean you, and I'm going to explain why in just a second. It's simply you're going to sit on the bedpan and they're going to take it away. You're not actively going to use it. So when you are the patient for this, you're going to get instructions. Put this gown on, get in bed, don't pee. Okay. When you're the CNA or the candidate testing for this, you're going to be told to follow the care plan. Good. And I'm going to explain why in just a second. Good. So that patient is going to be in bed for this particular skill, and charting is not required for this, not with Prometric. Here's our step-by-step instructions, our care plan at the top, our supplies at the bottom. But let's take a look at this specific care plan in detail. It says the resident has requested a bedpan. They hit the call light, got to go. Care plan says we have to help them with a bedpan. Says the resident is not wearing undergarments. So I don't care what your eyes see. What does our care plan say? So do not try to take clothing off of the patient during the test, because the evaluator will point at the care plan and say, what does the care plan say? Care plan says you don't need to do that step. They're not wearing undergarments. Those things do not exist. Got it? So nobody's going to be trying to pull your pants off. They shouldn't be. Okay. Then it says the resident is able to wipe self. Again, if somebody tries to get in your personal area and clean you up, the evaluator is going to stop them and say, what does your care plan say? They've done that already. Please do not do that. Okay. So the test is designed to keep people out of your personal space and keep you fully clothed. And the evaluator will intervene to make sure that these things are not violated. Okay, good. But that is the test. That doesn't always happen in real life. In real life, we may have to help our patients remove their underclothes to get ready for a bedpan, especially if they're laying in bed. It's kind of hard to get, your clothes off to get on the bedpan. You may have to help clean them, and I'm going to show you the physics of this in just a minute. You may have to help clean them. That's okay, but not for this patient. This patient, our care plan says they're doing it all on their own. Good? Make sense? All right. It says they're able to move and roll as directed, so cool. We can ask them to lift their hips. That makes this all way easier. We know all of this. We know to follow we know every skill starts with the opening, which is a knock. We know that we're dealing with body fluids, so we need a place to put all of our stuff. So we're going to use we know the patient should always be we know how to clean our basin, rinse it, dry it, store it. Bedpan's a basin, holds liquid. And we know at the end, bed's in low position. They've got their call light, all of the nice stuff, right? We know all this. There's nothing new to learn here. So let's pay attention to our skill-specific steps. That's what we're going to learn now. In order for me to teach this to you, I kind of have to explain toileting methods to you, okay? Because a lot of people think bedpan is our first choice. They think, okay, patient's got to go to the bathroom, bedpan, right? That's the first thing we go to. And I want to show you it's actually the last, and we're going to talk about why. So, interesting fact, toileting is actually a doctor's order, not set by the nurse. The nurse does not decide whether a patient uses a bedside commode, a bedpan, goes to the bathroom. That is a doctor's order. Got it? So if nurses can't make a change, do you think CNAs can make a change? And yet on Facebook and a lot of those CNA groups, I see a lot of CNAs that are like, yeah, I don't get the patient up out of bed if they're over 200 pounds. I just put a bedpan under them. They have changed the care plan. Are CNAs allowed to change the care plan? Especially with something that has to be done by doctor order. So if that CNA gets caught doing that, they are violating their scope of practice. If something happens to that patient, they are liable. Don't put yourself in that position. Got it? But when we're trying to decide how this patient should be toilet, and we know everybody's going to go, right? Everybody goes like multiple times a day. This is a non-negotiable. We have to know that. In fact, this is the very first thing we should know about a patient. I'll talk about teams reporting in a minute. Toileting is the very first thing you should know about a patient. So the first thing we find out is the patient continent? Can they go on their own? All of you guys are continent. I am not involved in your toileting. You might be in my room, but I am not involved. You do not have to raise your hand and say, Miss Patty, can I go potty? And I'm going to say, please don't ask. Go. I don't want to be involved in your toileting. You are competent adults. You can get up. You can take care of that yourself. I don't need to be in the loop. Okay. A lot of our patients are like that. If somebody is in the hospital for blood pressure management, they don't need our help with toileting. Why would they? They get up and they go. They're there for blood pressure. If somebody is there because they had a hip replacement, well, that changes things, doesn't it? Because now they can't get up out of bed to go. So every patient is going to have a different care plan. But the first thing I need to figure out is, are they continent? Can they take care of this by themselves without my input? I like those people. Okay. We call that bathroom privileges. Go whenever you need to. Don't need to be involved. Thank you. Now, sometimes patients can go when they need to, but they need a little help. Maybe they need help getting out of bed. Maybe they need help walking because they're a little unsteady. Maybe they need help getting up off the toilet because they're kind of low. And if our legs are really weak, might be kind of a hard thing to get ourselves off the toilet. So they might need help with that. Doesn't matter what the help is. We call that bathroom with assist. Bathroom privileges, top of the list. Ding, ding, ding. We have a winner. They take care of it themselves. Bathroom with assist, they're still going there. They just need some help somewhere along the way. Good? That is the gold standard. That's what I'm looking for. But what happens if the patient can't take care of their own bathroom needs? So are they continent? I mean, do they have the capability physically? We talked about incontinence. You guys remember that last week? We talked about incontinence. Well, if they're incontinent, we just do pericare every 2 hours. We already have a process for that. Clean them up, get them on dry pad every 2 hours. We have a process for that. What we're talking about here is if they're capable of holding and going. Good? Make sense? All right. So bathroom privileges or bathroom with assist, gold standard. That's what I'm looking for. But what if they can't make it all the way to the bathroom? Because, man, if you had to go from here all the way back there, that's a long walk when you have no energy. So maybe if they can't make it all the way to the bathroom, but otherwise they're okay, we might look at something like a bedside commode where we bring it to the bedside, literally, and they are able to get up out of bed, sit on the commode, go, CNAs clean it out, and then get back into bed. It's a shorter distance, shorter journey, but it still gives them that bathroom-like experience. Still feels like a toilet. Okay, good. That might be alone or with assist. Okay, they might need some help with the transfer, or they might be able to handle it themselves. Where would I go to find the information on this? The care plan. So our care plan might say bathroom privileges. We could do our little happy dance, right? Because they take care of it themselves. Bathroom with assist. Okay, they're going to hit the call light when they got to go, and we're going to help them. Bedside commode ad lib. That means they take care of it themselves. Just bring the bedside commode, clean it up. Bedside commode with assist. Okay, they're using the bedside commode, but we got to help them. Okay, we go through all of that before we get to our last two options. If my patient can't get to the bathroom, even with assist, if they can't use a bedside commode, even with assist, I've only got two options left. And the first one I'm going to look at is catheter. Is a catheter indicated for this patient? Now, it's important that we understand catheters are not used for convenience. Let me say that again. Catheters are not used for convenience. Catheter use has a very high incidence of catheter-acquired urinary tract infections, or something we call CAUTI, C-A-U-T-I. And we're going to see in just a minute, because we're going to go over catheter care in a minute, and I'm going to explain this to you. But catheters, when somebody gets a urinary tract infection with a catheter, it is way more severe and way quicker onset than a regular urinary tract infection. I'm going to show you why in a minute, but the catheter is literally a Trojan horse. It allows bacteria to hide inside the catheter, and then they can all jump out at the hole at the top into the bladder. And it's not a single bacteria that you're dealing with. It's 1 or 2 trillion bacteria that invade like that. And a lot of times our patients are not able to overcome that kind of infection, and it will kill patients. So we have to be very, very careful with this. We only use catheters if the pee can't come out on its own, or if the pee, when it comes out, causes a bigger problem. So let's say that I've got a huge open bed sore on the patient's bottom, their coccyx area, their, tailbone area, right? Huge open bed sore all the way to the bone. It happens. Yeah, stage 4, absolutely. All the way to the bone. I mean, I turn the patient over, I can see white. That's not a good deal. Remember, urine is acidic. What do you think acid does to that tissue of the open wound? It's going to burn it like crazy, and it's going to actually delay healing because we're constantly aggravating that tissue. Does that make sense? Can also alter the pH of the wound itself and allow other bacteria to grow in it. It's not a good deal. So if I've got a patient with a really bad coccyx wound and they're incontinent, well, a catheter might be a good decision there. Now, we know there's risks, so we have to weigh the risks and the benefits. But if we want any hope of being able to heal that coccyx wound, we may have to look at a catheter in the meantime. Make sense? If you're having surgery, catheters are going to be important, because when we put you to sleep, we put every part of you to sleep, including that little valve, which means you're going to pee on our sterile fields. We don't like that. We don't want pee in the ER or the OR. So we usually put a catheter in while you're under to help divert the urine that's going to, not might come out, going to come out. Okay. And then they remove it before you ever wake up, and you didn't even know you had one. Right? In that case, a catheter would be indicated, right? Because it's inconvenient. It's not a good, sound medical practice to have urine in a sterile field. Good? Make sense? So there are reasons we would use a catheter, but convenience for the CNAs is not one of them. So this we rule out pretty quickly. So all that I've got left is the bedpan. That's last resort. I had to go through all of this to get here. It wasn't my first pick. I didn't go straight to you hitting the call light and me coming in saying, do you want a bedpan? That's not what I did. Why? Why wouldn't this be the first resort? I mean, why wouldn't it be? Well, do you guys remember me saying with when we were talking about cognitive development, the memories we make early in life are really strong memories and they stick around for a long time. You guys remember that? Okay. When you were about this tall, Mama taught you, don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. When we put a bedpan under a patient, where are they? In bed. And it doesn't matter what we do, their brain is still saying, stop, we're in bed. This is a no-no. We can't do this. So even though you're trying to tell your brain, it's okay, it's all right, we can go. The nurse said it's okay. I can't get out of bed. I got to pee. We got to do something here. Your brain is still going to go, no. This is a very hard thing for a patient. And when we have patients on bedpans, it's very common for you to put a bedpan under a patient and then wait and wait and wait and nothing happens. You take the bedpan away, 10 minutes later, they're on the call light and they say, I got to pee. You're like, you just tried. You didn't get anywhere. Well, I don't care. I got to pee. So you put the bedpan back under the patient and you wait and you wait and wait and they can't go and you take it out. And the third time they hit the call light, you're ready to throw punches, right? It's not their fault. They've got a really good, strong working brain. We should be applauding that. That's a good thing. But that doesn't solve our patient got to pee problem, does it? So what can we do? Well, there's a couple things you can actually do. Number one, privacy rules here. People don't like to go with an audience. That makes sense, right? People don't like to go with an audience. Well, if you are in the cubicle with them, remove yourself. You don't want to stare somebody in the eye while they're trying to pee, okay? It's bad enough when your dog does it. Imagine a person that you don't know. Okay, doesn't work. Remove yourself. But we also have to be a little bit understanding that this provides no real privacy. Not for sound, not for smell, and we can still see shadows through it, right? This is not the partition at the Walmart bathroom. And how shy are you there? Okay, got it? So if your patient has a roommate that is ambulatory and has an order to go for a walk or is going to an activity or can get up and go to the bathroom, this is a really good time for that extra patient, that roommate, to exit stage left. Privacy matters here, because otherwise your patient may not be able to go. There are sounds and there are odors that accompany toileting habits, and your patient may be very sensitive to both. The fewer people in the room, the better the results are going to be. Make sense? These are things that we don't really think about too much. Now, the other thing that we can do that can help your patient is to turn on the water in a place that they can hear it. The sound of running water does help with the urinary letdown reflex. Have you ever had to go pee and somebody started saying rushing rivers, Niagara Falls, you know? It'll make you really want to go pretty quick. So the sound of running water can help with that. And then the last thing that I do when I've got somebody who really is having a hard time going, I actually learned from a mean 12-year-old girl, okay, during a sleepover. First girl to go to sleep, you put their wrist in warm water and they pee themselves. So what if I've got, oh yeah, try it. Next time your significant other is knocked out cold, right? Put their wrist in warm water. Yep, they'll wake up or they'll pee, one or the other. So if you have somebody who's having a particularly hard time with that urinary letdown reflex, get a basin of warm water and just have them put their hands in it and close their eyes and relax, and they will probably start going. So we can use all of these tools to help our patients kind of focus inward rather than being aware outward. Make sense? Do you guys understand why bedpan's last resort? We don't go straight for it. If the patient hits call light and says, I gotta pee, and you don't know what their bathroom status is, don't just grab the bedpan and go for it. We have to figure out what their bathroom status is. Good? Make sense? We're going to come back to this in just a second, but right now I want you to go to page 115. I don't have a slide for this, but go to page 115 in your books, and I want to talk about this. When you come on to shift, no matter where you work, when you come on to shift, you are going to get a shift report. That shift report is going to tell you who your patients are and what to expect. It also gives you some details about their care plan so you can hit the ground running. We call this the TEAMS report, TEAMS. T stands for toileting because that's the first thing you need to know about your patients. How do they toilet? Because I can almost guarantee you during shift report, a call light is going to go off and somebody is going to say, I gotta pee. First thing you need to know. The second thing you need to know is how do they eat? Because everybody eats on every shift, even night shift. People want midnight snacks. They get picky, hungry. So how do they eat? What diet are they on? You guys just read chapter 8. Diets matter. What diet are they on? Liquid, are we encouraging fluids or are we restricting fluids, right? Do we have to puree their food? Do we have to thicken their liquids, right? What do we need to know about that? Because every shift, you are going to have to do something, whether it's food or fluid with that patient. You also need to know, are they on intake and output? That's important. We've already talked about that. Good so far? So toileting is always first. It's first thing I need to know about every patient I take care of. How do they toilet? Second thing is, what do they eat? The third thing is ADLs. Yeah, that's just your basic, right? Bathing, dressing, grooming. What do I need to know about that? That's a little further down the list because if I get to it, I get to it. If I don't, I don't. But toileting and eating, that's going to be a priority. Then we get to M, mobility. Mobility is how much mobility the patient has. Are they confined to bed? Can they roll themselves? Do I get them up? Do they go to a chair? Are they walking? Do they walk around? Can I find them at Subway if they go missing, right? I need to know what their mobility status is. Are they wheelchair bound? What is their mobility? And then S is special. It's for everything else that's not covered. And there's very few things in the S category for CNAs. You would need to know vital signs here, right? How often do I have to take their vital signs? You would want to know if they had a fall last night, so you can keep an eye on them. You would want to know here if they're fighting with their roommate. That might be important information. If a family is coming to visit at 9 a.m., you know you've got to get them up and dressed before that, right? So S special, it's everything that doesn't fit into one of those categories. If you look at this, this is everything a CNA needs to know about their patients before they start shift. And if you get used to using this method, this TEAMS method, you can get a shift report on 16 people in 15 minutes. It's quick because it's organized. Make sense? So a shift report would go something like this. This is Miss Sally Mae. She is an 82-year-old female. She is bedbound, uses a bedpan. She needs to be turned and repositioned every 2 hours around the clock. She eats in bed, soft diet, mechanical soft diet. Her ADLs are total. She can't do anything for herself. She does remain in bed. We don't get her out of bed, but we do turn and reposition. And we do her vital signs once a shift on the 7 to 3 shift. That took 15 seconds. And it's organized. If you do that for every single one of your patients, your shift reports go super smooth. So you need to know about that TEAMS report. Okay, so let's go back to our bedpan. All right, so when we're talking about skill-specific steps, our bedpan actually says the resident's able to move as directed. So I can ask this patient, can you lift your hips? That makes life so much easier, so much easier. But what if your patient can't? Well, for the test, it tells us we can, so yay. But in a clinical setting, you are going to have patients that can't lift their hips. In that case, you scoot them towards you and you roll them up on their side. You put the bedpan against their butt, roll them back on their back, on the bedpan, let them go. And then when they're done going, they're going to roll off of that bedpan. But if you're not holding that bedpan flat, what's going to happen to it? It's going to go with them. So when they roll off the bedpan, you're going to hold that bedpan flat as they roll off of it and take it away. Got it? You'll only make that mistake once in your life, and you will learn. Yes, I'm speaking from experience. Okay, so since we have this lifting of the hips or rolling or whatever we're doing, whatever's in that bedpan is going to slosh. So we want to protect the sheets under that bedpan, and we have something specifically for that purpose. A chucks. Do you guys remember clean rolls toward me, dirty rolls away? You already know how to do this. See, we're building on things we already know. So we roll the chucks, put it under the patient, and unroll it flat. Then we're going to put the bedpan under the bottom. Bedpans are always in the bottom drawer. Do not ever put a bedpan above a toothbrush, right? Bedpans, toileting, bottom drawer. These drawers are always arranged in the order of the body. Grooming, top. Bathing, middle. Toileting, bottom. So your supplies in here follow the human body. Good? But during the exam, they're going to show you where everything is. This is a bedpan, just like this. Good? This looks like a toilet seat. It's where the butt goes. Do not think that your patient wants to perch on this. This is not good for sitting. This is not what I would call comfortable, but way more comfortable than this. Okay, good. So this part goes under the patient's bottom. It's also wider for the wider part of the patient. Good, good. Okay, let's talk physics. This is the widest, deepest part of the bedpan. Deepest. Here, where your patient's undercarriage currently sits, is this deep. We have liquid under pressure being forced out of the body, hitting a flat plastic surface this far away. Let me explain this to you guys, and there's no easy way to put this. Have you ever peed and had water splash back up on your bottom? You know the ick you get with that? Yeah, that water is this far away. We are working with this far away. You're going to get splashback. Your patient's going to be icked out. This is not the best option for toileting. Good? Now, if they have a robust bowel movement, yes, it's going to touch. Again, not high on my I want to do that meter. Okay? So physics here. But you've also got, even if you have a splashback effect, because you've got water under pressure, hold that for me, water under pressure hitting that flat plastic surface, it's going to splash back. So the undercarriage of your patient is going to get wet. I mean, there's not much we can do about that, except if the nurse tells you or the care plan tells you, there's a cheat you can use that makes this way easier for your patient. Take toilet paper, big loops of toilet paper, 5 or 6 big loops of toilet paper, and you lay it in the bottom of the bedpan. It absorbs that urine. It prevents that splashback effect, and it keeps your patient's undercarriage a little bit drier. Okay. Now we can't use that if we're doing I's and O's. You guys remember intake and output? That means we measure everything going in and everything coming out. So we can't measure it if you got it all absorbed by the toilet paper. So if the patient's on intake and output, sorry, no TP. If the patient's not on intake and output, kick your heels and joy, because this is going to be easier for your patient. Good. How do we know if we can use that? Care plan, is that a decision we can make? No, so I'm going to ask the nurse, can I put toilet paper in the... Now, some CNAs, again, decide to do things on their own. And they will put a plastic, like a Walmart bag, inside the bedpan. Okay, that doesn't really, all that does is it keeps that CNA from thinking that they have to clean the bedpan, right? Because the urine was in the bag, not the bed. Yeah, it doesn't just stay in the bag, guys. But you're trying to cut your time and you're making it a little more uncomfortable for the patient. Is that really what we should be doing here? No care plan is going to tell you to use a bag. That's just not a thing, right? That's a CNA, I made this up to make my job easier thing. Does that make sense? Toilet paper is a thing, though. It is a best nursing practice if your patient isn't on output measurements. Good? But it also helps with that splashback because that toilet paper absorbs rather than reflects. Good? Make sense? So that's a trick you can use. Now there's another trick that I want to talk about. This bedpan is plastic. How many of you guys in your cars have plastic or pleather seats, right? Where they're not cloth? When you sit on those seats in the summer in your shorts, what happens to your skin? It sticks, right? Because the plastic that you're sitting on is heated up. Well, body temperature is 98.6, about the same temperature as outside right now, right? 98.6 degrees. It's going to heat up this plastic, which means your patient's bottom is going to stick to the bedpan. It's going to stick. So when they lift up to come off that bedpan's going to lift too. And whatever's in the bedpan is now all over your bed and your patient. Not comfortable. So there is a way around this. Again, we're going to ask the nurse. Have to ask the nurse. But we can put cornstarch or non-talc powder on here, and that helps prevent the patient from sticking to it. It helps it slide under the patient super easy, but more importantly, after the patient's been sitting on it for a few minutes, it helps it slide right out without sticking. We cannot use this if our patient has a respiratory condition, though. We cannot use that if the patient has an open wound or an incision, because you don't want those fine particles, powder particles, to embed themselves in a wound or an incision. So this is a nursing judgment whether powder can be used and toilet paper can absorb. Good. For the test, we will use neither. We will use neither. But I need you to understand those are two tools that you do have in your tool bag if your nurse allows you to use them. That will make this much more comfortable for the patient. Good? Questions? Okay, so we want to make sure when we're putting this bedpan under the patient, we're putting the correct side of the bedpan, correct end, in the correct place. So the wider part of the bedpan under the widest part of the patient. And you want to make sure that it's on a barrier of some kind. What position do you normally use the bathroom in? Sitting position. That's comfortable for you. You're also having gravity help you out. Well, if your patient is laying flat on their back, that's not comfortable. It's not normal, nor do we have gravity helping us. So if you put a bedpan under the patient, leaving them flat is the worst thing you can do. But there's another problem with that. Let me show you visually. If I have, show you on my little table here. If I have a patient laying in bed, right? This is my patient, this is my bed, and I put a bedpan under that patient's bottom. What does it do to their bottom? Yes. Oh, 1 second. Raises it up. Absolutely. If that patient pees, that urine is going right up their back and into their hair. It did not go in the bedpan because of gravity. So if I put a bedpan under the patient and I want that urine to go in the bedpan where it belongs, I need to get the patient into a sitting position. This is the most important step of bedpan. The most important step has nothing to do with bedpan. It has to do with the head of the bed. Good? All right. Dom says, I just want to tell you thank you for your videos. I took my exam on Wednesday the 12th and passed. Appreciate what you're doing. Congratulations. Super proud of you. Great job. Thank you for including us in your journey. All right. So when we put the bedpan under the patient, we're going to put the head of the bed up. Good? But I just put that chucks under the patient, bless you, and the bedpan under the patient. I now have butt juice gloves. Do I want to touch that bed controller with butt juice gloves? No. So what do I need to do before I touch that controller? Yeah, take those butt juice gloves off. Absolutely. Good. So we're going to leave our patient in a sitting position on the bedpan, and we're going to step away so that they have some privacy. Now, this is where it's going to be a little different for the test versus real life. In a clinical setting, you've got lots of things to do. You do not have the luxury of standing there for 10 minutes waiting for your patient to use the bedpan. You're not just going to stand there idly. You're going to wash your hands to get rid of that patient's cooties, and we're going to go take care of somebody else. This is a great time to take the roommate for a walk or help them to the bathroom, but we're going to wash our hands, right? Got it? In the testing setting, you have no other patients. This is your only patient. But even more importantly, you don't have anywhere you can go because the testing center is one room. There's nowhere to go. So you're going to step on the other side of the curtain and you're going to wait. But in a clinical setting, please don't do that. That's just creepy. Wash your hands, leave the room. But for the test, because we're staying in the room, we're not going to another patient. We're not leaving the patient environment. We don't have to wash our hands. We're just going to wait. Good? Everybody understand the difference there? Okay. We're going to stand and wait. Once the patient says, I'm done, and remember, they're not really using the bedpan, right? We just put it under them. They're fully clothed, not really using it. After about 3 seconds, they're going to say, I'm done. And you're going to come back around the curtain and we're going to finish up the skill. Got it? Simulation skill. Well, your patient didn't really pee in the bedpan, so there's nothing in the bedpan, but we're going to pretend there is for this next part. Good? So putting the bedpan under the patient is step 1. Taking it out is going to be step 2. Now, before we walk away from this patient, though, remember our care plan said that they're able to wipe themselves? Well, that means they have to have the resources to do so. So before we walk away from that patient, they need their toilet paper and they need their call light to let us know when they're done. So we're going to get our patient in a sitting position with the bedpan under them, chucks under that. We're going to give them their call light and their toilet paper, and then we're going to walk on the other side of the curtain and we're going to wait until they say, I'm done. When they say, I'm done, we're going to come back around and lower the head of that bed. Because if a patient is sitting on that bedpan, it's going to be really hard to pull it out from under them because their body weight is pressing it down into the mattress. We need them laying down so they can lift their hips, and then we can pull that bedpan out. Whatever's in this bedpan is nobody's business. We don't want to take an empty or a full container of body waste uncovered through a patient area. That's an invasion of privacy. Nobody needs to see this. So when I take this bedpan out, I take the chucks with it all at once. So the bedpan and the chucks all at once out from under the patient. Good. Now we're going to take that covered bedpan over to the toilet, and we're going to dump our pretend pee into the toilet. Sorry. We're going to dump our pretend pee into the toilet. Nothing's going to be in the bedpan, but we're going to pretend. And then we're going to clean our basin like we clean all basins. We're going to rinse it. We're going to put the rinse water into the toilet. We're going to dry it, and we're going to store it. Do you not throw a bedpan away every time the patient uses it? Do you throw your toilet away every time you use it? And sometimes you really abuse that toilet, don't you? You don't throw it away. That would be ridiculous. We don't throw bedpans away either. We clean them. This is a disturbing trend that we're seeing in healthcare. CNAs are throwing bedpans away instead of cleaning them. It's a disturbing trend. Please do not participate in that because the cost is being passed on to your patient. All right, so let's talk about cleaning that bedpan. Some healthcare settings, usually acute care settings like hospitals and rehabs, the toilets look like this. In fact, this is a picture I took last time my mom was in the hospital. Okay, this is one of our local hospitals right down the road. And the toilet is very industrial. It has the seat. But if you look here at this water pipe, there's something that looks like a little shower head. If you bend that forward, so if I bend it forward, it's going to end up right over that toilet bowl. And it'll spray water into the toilet bowl. And it allows you to clean the bedpan in the toilet rather than taking it to the sink where the patient's going to brush their teeth later. Okay, good? Make sense? Great option. Fantastic option. Except you've got water under pressure hitting a flat plastic surface that is currently filled with body waste. You will have splashback. And this time, the object of the splashback is you. That's no good. So if we use a bedpan cleaner, we have to dress for the occasion. We're going to put one of those isolation gowns, you know, the yellow disposable gowns that you see in healthcare. We put one of those on over our clothing, and the practice kit has those. We put one of those on over our clothing. You want something over the holes in your face. So a mask with a face shield or goggles. You don't want that body waste to be propelled into any of your holes. Okay, so you want to cover your holes. Let's talk about odors real quick. People think masks help with odors. They don't. Masks do not filter odors. So there's a couple of options that you have if you're particularly odor sensitive. Years and years ago, we only had one option. It was Vicks beneath the nose. We just put some Vicks there. But my skin is so sensitive that I look like Rudolph, like within 30 seconds. I mean, I will be bright red. So I used to make my own. I'd go get a little container of Vaseline that I would get like at the dollar store. I'd put a couple of drops of essential oils, and I like the orange blossom or lemongrass, mix it in, and I would use that. And it hydrated my skin. It was great, right? And you can still do that. That's fine. But now they've got these really cool rings. They're plastic rings. They're impregnated with scents, very strong scents, and you just pop them, you know, right into, you don't have to drill holes. It just, they just pop right here on the out, you know, holding on to the inner septum of your nose, and it helps with odors. Great. I wish I'd come up with that invention. Whoever invented that is going to make a fortune with healthcare. But you can get those, and they're cheap, and they last. Like, you can use them over and over and over. So look into those, okay? If you're odor sensitive. Good? Questions? All right, so we know our patient wiped themselves. How do we know that? Care plan. I know where their hands have been. We need to get those hands clean. So we're going to give them a hand wipe when we're all done with this. We take our gloves off. We give them a hand wipe, but I know where their hands have been. I don't want to touch that hand wipe. So I'm going to get a paper towel to collect that hand wipe. Throw it away. Good? Good? Not a hard skill. Not a hard skill. Put the chucks underneath them. Put the bedpan on the chucks. Elevate the head of the bed. Give them the call light and toilet paper. Wait. Lower the head of the bed. Pull the bedpan and chucks out together. Wrap the chucks over the bedpan. Go to the bathroom. Clean it. Dry it. Store it. Put it away. Right? Take your gloves off. Give them a hand wipe. Collect it with a paper towel. Do your closing. That's the whole skill. Not a hard skill. So let's check it off here. We're going to follow our care plan. We're going to do our opening. We're going to wear gloves. Yes, you need gloves, body fluids. We're not going to go on break yet. We're going to use our barrier. Now, I want to talk to you about the barrier real quick because I don't agree with this. This is my own personal issue. What do patients use this table for? Everything, but specifically, give me some specifics. Eating, there it is. Patients are eating on this. Has food tray, yeah, but patients are eating on this. Me personally, I don't want toileting items on my dining room table. I'm going to have a problem with that. Even if you put it on a barrier, I'm still going to have a problem with that because toileting and eating should never occur in the same place. Like, I'm not going to take a Twinkie into the bathroom and have a seat. Right? Toileting and eating do not happen in the same place. Some of you might be perfectly okay with that, and that's fine. For me, it's pretty high on my gross meter. I don't like putting a barrier on this table and putting the bedpan on the barrier. Now, you're going to see it in the video because that's what our care plan says, right? To put the bedpan on the barrier. That's fine. We're going to do it this way. But I'm going to tell you, in a clinical setting, if you watch my older videos, you can see this. In a clinical setting, you don't have to pull that bedpan out until right before you're going to put it under their butt. So you can put a barrier on the table and put the hand wipes there, put the gloves there. That's all fine. That's fine. But I'm leaving that bedpan right where it lives until I'm ready to pop it under their butt. That way I'm not putting the bedpan on an eating surface. It's not a graded checkpoint. If you put the bedpan up here, it's fine as long as there's a barrier. They're okay with it. I'm not. You guys get the difference there? Okay. So to me, that's just kind of a gross thing. All right, patients should always be in the center of the bed. We're going to clean our basin the way we clean everything else. And we're going to follow those steps we just talked about. We'll finish up with the closing. So this isn't a hard skill as long as you kind of know a little bit about the patient needs to be in an upright position, the bedpan needs to be covered, those types of things, which I just made a big deal out of. Okay. This care plan is only for this patient. This one goes to the bathroom. This one has a catheter. This one uses a bedside commode. This one uses a bedpan. Those are all different care plans, guys. Let's take a look at this video.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I understand you need a bedpan. Can I help you with that?
Yes, please.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. After I've washed my hands, I'm going to get my supplies. I'll start with a barrier, unfolding it, with the absorbent side facing up, and this is going to give me a clean place to put my clean supplies. And we're going to start with the chucks, and then I'll move over here to the patient environment. I need a set of gloves, a second set of gloves, hand wipes, and I'll need the bedpan, which will be in the bottom drawer. I'm going to open the drawer, but I'm not going to touch the bedpan until I put my gloves on. We'll go ahead and put the gloves on. I'll take the barrier and prepare it by holding it up with the absorbent side facing me, and I'm going to roll it toward me. And we're going to set that aside. I'll get the bedpan and the toilet paper out of the drawer, and we'll put those on the bedside table. Now we're ready to start the skill. Okay, Mr. Jones, I'm going to ask you in just a moment to bend your knees and put your feet flat on the bed, and you're going to lift your hips up for me so I can unroll this chucks underneath you. This is going to protect your bedding while you use the bedpan. Okay? So I'm just going to loosen this sheet up a little bit so we've got some working room. I'll take my prepared chucks, and we're going to place it on the bed where we're going to unroll it under the patient. It needs to be under the middle of the patient where the bedpan is going to go to protect the sheets from becoming soiled. Mr. Jones, can you bend your knees? And I want you to lift your hips as high as you can go. Thank you. I'll unroll that chucks all the way to the other end. Okay, you can relax. There you go. Now we're going to put the bedpan under the patient. The wider end of the bedpan goes under the patient's buttocks. So this will be toward the foot of the bed. Mr. Jones, can you lift for me? Thank you. Go ahead and come down. Make sure that that's centered appropriately. All right. And now I can remove this set of gloves. We'll throw these gloves away, and I'm going to put the head of the bed up. Mr. Jones, I'll put the head of the bed up now. That bedpan may shift a little bit. Feel free to move it as you need to, and let me know when you're comfortable. And you can relax your legs. So you comfortable? Okay. Here's your toilet paper. Here's your call light. I'm just going to step on the other side of the curtain and let me know when you're done. Okay, Mr. Jones, are you done?
I am.
Very good. Let me lower the head of the bed. There we go. And I'm going to put my gloves on. All right, Mr. Jones, in just a moment, I'm going to ask you to bend your knees and lift your hips off of the bedpan, but wait until I tell you because I need to hold that bedpan flat.
Okay.
Okay? I'm just going to move this out of the way. I'll take a corner of the chucks. Go ahead and bend your knees. Don't lift yet. I'm going to take a corner of the chucks and hold the front of that bedpan down as he lifts. Go ahead and lift, and I'll pull the whole chucks and bedpan out. Relax. And we're going to take this to the bathroom for disposal. I'll bring the bedpan over to the patient bathroom area. We'll unwrap the chucks from around the bedpan and dispose of the chucks. And then we're going to dispose of the contents of the bedpan into the bedside commode. For testing, this is a simulation skill. There will not be anything in the bedpan, but we're still going to follow through with the simulation. We'll lift up both the seat and the lid. We're going to dispose of the contents of the bedpan into the bedside commode or toilet. And then we're going to rinse the bedpan. We want to put the rinse water into the commode as well. Now I'm going to set the bedpan down into the sink, disinfect it per facility policy, and then use a paper towel to pick it up. I'll take a paper towel to dry the inside. Throw that away. Another paper towel to dry the outside. Throw that away. And then one more for the drawer. Now that I've cleaned the bedpan, I'll get the toilet paper, place it in the bedpan, open the drawer with the paper towel, and then we're going to position this bedpan in the drawer and close the drawer with the paper towels. I'll then throw these paper towels away. We're going to remove the gloves and throw those away. I'll get a paper towel. Mr. Jones, I'm going to give you a hand wipe so you can wash your hands after using the bedpan. Go ahead and take a hand wipe. And then I'll collect that hand wipe after you're done with the paper towel.
Thank you.
This keeps me from touching the hand wipe. We'll throw this away. We're going to throw the barrier away. Clean our work environment. So I'll pull the sheet up. Make sure that it looks good. And here's your call light, Mr. Jones. If you need anything at all, just press that red button and we'll be happy to come back and help you. I'm going to remove your bedside table and open your privacy curtain. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your bed is in the low position. Your environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Any questions on that one?
Why do you use a paper towel to get the sanitizing wipe? Because if the sanitizing wipe's like really wet, won't it go through the paper towel?
It could, but by the time they've washed, wiped their hands with it, most of the moisture is on their hands rather than the paper towel or rather than the wipe. But if you want to use another paper towel, that's fine. That's fine. I just don't want you to use that. We know that those gloves have body fluids on them, right? Because we cleaned the bedpan with them. I don't want to touch the outside of the wipe container with those gloves. And that's primarily because of this. What skill did we learn on Wednesday that we use a hand wipe for before we do something to them? Look at your syllabus. The skills that we did Wednesday, I'm not going to give you the answer. I'm going to make you work it out. The skills we did Wednesday was transfer from bed to wheelchair, feeding the resident in a chair, and peri-care. Which one of those did we use a hand wipe for? Say it. Feeding. We gave the patient a hand wipe to wipe their hands because washing our hands before we eat is part of the eating ritual. You guys remember that? So if that hand wipe container is used for eating or feeding our patient, do we want to touch it with dirty gloves? No. That's why we want to remove our gloves before we get the hand wipe container. Does that make sense? Good? Questions?
When you're in the test and you walk behind the curtain, do you have to simulate that you would wash your hands if you
No, because you only have one patient. Yeah, you're fine. You're fine there. Good question. Any others? This is not a hard skill. It is a little bit on the longer side. It is a little bit of a long, so you get 2 short skills to go with it. That's not a bad deal, right? If you go to page 25, see if you can find the care plan set that has bedpan on it. Do you see it?
Feeding a resident in a chair and passive range of motion.
Okay. So what I just said is very relevant, isn't it? The 2 skills that you need those hand wipes for are on the same care plan set. So first we're feeding the patient, then we're doing range of motion on them, then we're helping them with the bedpan. So that means that the skill set that has bedpan also has feeding. I don't think that's much of a coincidence. Make sense? Good? Questions? All right. Normally I would put us off until about 10:45 to do our break. We're going to do our break early today for a reason. The next 2 skills that we're going to do, catheter care and drainage bag, I'm going to teach you together because there's a lot of overlap between them. Okay. So I'm going to give you both of those lectures together, show you both of those videos, and then we'll open it up for practice after that. So because it's kind of a longer 2 skills that I have to show you together, let's do our break early. And then when we get back, we'll go through those 2 skills, and then the rest of the class will be practice for you. Okay. All right. Go ahead and take your break. All right. Questions so far? Let's talk about a catheter. If you look on page 158 down here, you can see all of the principles involved in this skill. They're all spelled out for us here. These are our our skill specific steps we still have to talk about. Down here is our testing information. Somebody with your level of experience should be able to do this in 15 minutes or less. Do you guys remember PeriCare? Remember PeriCare? This is PeriCare with an extra step. They gave us 17 minutes for PeriCare. They're giving us 15 minutes to do catheter care.
Oh,
So I need you to understand that almost every skill that I talk about, I say you got plenty of time. Slow down, you got plenty of time. This is a skill you're going to need to practice because you actually have less time to do this than the skill that's a part of this. So you need to practice this one and have it under your belt. Good. Questions? Questions? Okay. This is a mannequin skill. That mannequin will be in bed. This is not a charting skill. Page 159 gives you your care plan at the top of the page, step-by-step instructions, and your supply list. Let's look at this care plan. It says, provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and the perineal area around the catheter. So we're cleaning the catheter and the tubing. We're going to use PeriCare techniques. I'm sorry, we're cleaning the catheter and the skin around it. We're going to use PeriCare techniques to clean the skin part. This is PeriCare review. Okay, so I want to talk about PeriCare for a second, and then I'm going to show you the differences. With PeriCare, they already had a chucks under them. We replaced it with a dry one. Then we cleaned the peri area, top to bottom, middle, side, skin fold, wash, rinse, dried. Then we turned the patient over and cleaned their backside. Then we changed that chucks again. You guys remember that with PeriCare? Okay, catheter care is just a little bit different. With catheter care, they don't start out with a pad under them. They don't need one there because they have a catheter to catch the urine. So we put a chucks there. We don't replace it, we put it. Got it? Different? Then we're going to do PeriCare, middle, side, skin fold, wash, rinse, dry, just like we did with PeriCare. Then we clean the tubing instead of the backside. The reason that we needed to clean the backside with PeriCare is because the backside was laying on that wet pad. Urine on the skin, no good. We got to get that urine off the skin. So PeriCare is front and back. Catheter care is front and tube. Do you guys see the difference there? The tube takes less time to clean than the backside. That's why you get less time. Okay? Other than that, I mean, you pretty much know this skill. And then when we finish the skill, we don't leave a pad under them. We remove the one that we put there. Now, why aren't we leaving a pad under the patient? Well, pads are plastic lined, which means they're going to hold in body heat, which is going to make the patient sweat. So we end up with warm, dark, moist. So it's best to not use a pad unless we have a need to use the pad. This case, the urine is being collected by the tube, not under the patient. We have no need for that pad. So PeriCare, replace the pad. Clean the front, clean the back, replace the pad again. Catheter care, put a pad, clean the front, clean the tube, remove the pad. Got it? Very similar skills. Very similar skills. There's not much for me to teach you with this. You know how to do this skill, right? You know how to do this skill. These are our differences. We're not going to clean the backside. We're not going to leave them on a chucks. What I need to teach you with this skill is what a catheter is, how it works, and make you a little less afraid of the catheter. That's what I have to teach you with this skill, because everybody's a little like freaked out over catheters. So we want to talk about it. Nurses insert and remove catheters. CNAs do not do that without additional training. There are some instances in some states where you can be trained to remove catheters. If a nurse asks you, hey, will you remove this catheter, and you have not been trained, what do you tell them? No, haven't been trained. If somebody hires you and says, we want to train you to remove catheters, okay, you're open to training, but you have to be trained. You can't just do it on, can't watch a YouTube video and hope for the best. Okay, got to be trained. Remember, training does not have to happen in a classroom. It can happen at the bedside, but you still need to be trained. Catheters actually are really easy to take out. Super easy to take out. They're not all that hard to put in either, but sterile technique comes in there because we don't want to introduce bacteria into the bladder. That's why nurses generally have to put them in, but CNAs can be trained to take them out. So let me explain how this might work. Let's say that you go to work for a same-day surgery center. This is a place where people come in early in the morning, they get checked in, they have their surgeries right there. We keep them for a couple hours, make sure everything's cool, and then we send them home. Remember I told you earlier, we usually put a catheter in during surgery, right? So that means this patient's going to have a catheter taken out before they can go home. So if you work in pre-op before they go to surgery, you're probably not going to have anything to do with the catheters other than sending the patient to the bathroom before we put the catheter in. I mean, you're not really going to have much to do with this. But if you work in the post-op section, I may want to train you to take out, these are stable patients. We're getting ready to send them home in like 5 minutes, right? So you might be trained to take out a catheter because this is a routine task on a stable patient. Good? Make sense? Okay. All right. So nurses put catheters in and most of the time take them out. How does this work? How do we put catheters in? First of all, putting a catheter in should not hurt. That's kind of a, how do I put it? It should not hurt. Now, there are some kind of caveats to that, okay? But catheters should not hurt going in or coming out. When a catheter is put in, I'm going to pass this catheter around so you guys can see it. When a catheter is put in, it's deflated. It kind of looks like this. It's actually much smoother than this because this one's been inflated, so we stretch the balloon. It's very smooth. We lubricate it, and it goes in a hole that's already there. You pee through that hole every single day. We're not drilling anything. We're not creating new holes. It's no different than putting an earring through a hole that's already there. Okay? We're putting a tube through a hole that exists. Now, the difference is that your earring probably is significantly smaller than the hole you're putting it in. With this, it's got to be roughly the same size as the hole we're putting it in. Otherwise, the liquid will leak out around the tubing. So when we put a catheter in, we want it to fit snugly, which is the discomfort that people feel. Now, discomfort is different than pain. It would be like if you put an earring in that was way too big for your hole, right? It doesn't, I mean, it's not like serious pain, but it's irritating. You're going to be like hitting it all day and messing with it, right? So that's kind of the similarity between a catheter and being put in, because it has to take up all of that space. It's going to be an irritation until you get used to it. Good, makes sense? But it should not hurt. If the patient says, ow, 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 it hurts, that's something different. That's actually not because of the catheter itself exerting pressure. When patients say, ow, 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 and they're in real pain with a catheter, what's happening is not here. It's actually here in the bladder. Because in a small percentage of people, like less than 2% of people, when you put a catheter in And because we have this bladder empty, it's compressed, it's small. So the tip of this catheter hits the top of the bladder. It's, small. We're keeping the bladder small. So the tip of the catheter hits the top of the bladder. Well, in some people, like less than 2% of people, the bladder freaks out and it spasms because it thinks that this is a foreign object, and it is. And it spasms. Have you ever had a Charlie horse? How bad do Charlie horses hurt? Like on a scale of 1 to 10, 43, right? They hurt, don't they? Well, in this situation, the patient is having a Charlie horse of the bladder. And yes, this hurts. Your patient will go, ow, 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 and they'll probably be in tears. And this is a don't walk, run to the nurse situation because we want to get that patient out of pain pretty quick. Okay, easiest way, remove that catheter. Remove the source of the problem. But that's going to be a problem, though. It's going to be a big problem if my patient needs the catheter. So I may have to come up with some other options. And we do have a medication that we can give these people that put their bladder to sleep. Makes them much more comfortable. The problem is every medication has a side effect, doesn't it? And a risk involved. Some people, the bladder doesn't ever wake back up. Ever. So we have to be very, very careful and look at risk factors and, use scenarios and try to figure out with the patient the best course of action for them. But it all starts with you noticing the patient is in pain and reporting that to the nurse so we can come up with plan B. Good? Make sense? Now, some people will have a different kind of a reaction with catheters, and it all has to do with this hitting the top of the bladder again. Instead of a Charlie horse, this time with these people, way more common, they feel like they have to pee. So they have a catheter in, they'll call it, they'll go, I feel like I got to pee. And CNAs will go something like, well, just go. It's just going, they're opening that valve, which is being held open by the tube. So you're telling them to do something that's statistically impossible. They can't open a valve that's already open. What's happening here is the tip of this catheter hitting the top of that bladder because it's staying small. Is the only thing that's ever hit the top of that bladder before ever is pee. So when the tip of the catheter hits the top of the bladder, the brain says, oh, we must have to pee. And that's what triggers that, oh my gosh, I got a pee feeling. Make sense? Your bladder will get used to that. 10 to 12 hours. The bladder starts to, oh, this is our new normal, okay. But that 10 to 12 hours can be very irritating because the patient always feels like they have to pee. Distraction is our friend here. Watch a movie, read a book, get involved in something, pick up crocheting. Okay, do something that gets your mind going so that we can get through this next little bit. But I have to pee, way different from ow, 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 ow. Both of those still have to be reported to the nurse. But ow, 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 ow requires the run, not the walk. Got it? Do you understand the mechanics here? Whenever possible, we try not to use these things. If we can get away with no catheter, we're better off with no catheter. But sometimes we don't have a choice. So the nurse takes the catheter, deflated, inserts it up into the bladder, and then fills a balloon with a syringe. And when that balloon is filled, it sits right on top of that valve. And what that does is it keeps this balloon from going down through that valve. This balloon is nothing more than a doorstop. That's it. All this balloon does is keep it from going through that valve. It keeps it in the bladder. Now, if I want to take that catheter out, I need to deflate the balloon, syringe, pull the water out. Balloon is deflated, and it will literally slide out just like spaghetti. Okay? Good? Are you less afraid of catheters now? It is a straw. It's a flexible straw. That's all it is. A straw lets liquid. Where's my drink? A straw lets liquid go from one end through the other. That's all a straw does. That's all this does. Lets liquid go from one end to the other.
Why is it showing it with like two little at the bottom?
Okay, we're going to talk about that. Yep.
I'm rushing.
Yep. So this part right here is where we put water in and take water out.
Okay.
And if you look closely at it, it's really hard to see. I'm going to pass this around. But if you look really closely, you can actually, if you kind of twirl it, you can see the tube in the tube. This part connects just to the balloon through a tube. Okay, and that sits on top of the actual hollow catheter itself. So let me pass that around, and you guys can practice. The part with the white tip is where we inflate and deflate. Okay, so go ahead and play around with that. All right. So to remove the catheter, we just empty the balloon and then the catheter just slides right out. CNAs are responsible for cleaning the catheter. We keep the catheter clean, we keep the skin around it clean, and we empty the drainage bags. That's our responsibility with the catheter, and to report anything we see, hear, smell, or feel that's kind of funky, right? Catheter bags, catheters are attached to bags. Because if we're going to divert the urine, we have to have a place to put it. So catheters are attached to bags, and those bags need to be on a non-moving part of the bed above the floor. What's allowed to touch the floor? Yeah, shoes, right? Bags do not touch the floor. We want to make sure it's not kinked either. So these are the parts of the whole system. So far, we've talked about the catheter. Now we're going to talk about the bag. So at the top of the catheter, we have a tip with holes. This is what allows the urine to go down inside the catheter, okay? Tip with holes. Fun fact, catheters used to be glass.
No.
When they were first invented way back when. And they also used to be shaped like an actual straw. But we found that these are kind of hard to put in, right? So somewhere along the line, somebody said, hey, if we enclose that and put the hole on the side, might get us a little further. So, you know, medicine is a work in progress. Of course, this was 200 years ago, guys. We've advanced since then. So the tip is enclosed to make it easy to put in, and the holes are on the side. We also have that balloon we've already talked about that just sits on top of the valve to hold it in place, nothing more than a doorstop. And then you have the catheter tubing itself. That's just where the urine runs. Nothing to write home about there. Now at the bottom, you have these two terminal ports. One of them is where we put the water in and take it out. The other one is going to attach to some sort of a collection device. We got to collect that urine that we're diverting out of the bladder. So it connects to some sort of a bag. That's what I have here. This is the bag that you'll be using on the state exam. There's different kinds of bags. They all work pretty much the same. They hold urine. Pretty much it. This port here is what attaches to the other port of the catheter. And it literally plugs in. But it's snug. You kind of have to work at it because, again, we don't want leakage, okay? So one port allows us to put water in and out of that balloon. The other port allows us to attach some sort of a collection device. These are two separate pieces, and I'll explain why in a minute. Good? Good? All right. So the bag itself has the plug-in port as well as the tubing. The bag that has what we call eyeball measurements. We don't use this to measure. This is just a rough estimate. It has like for little teeny tiny rough estimate measurements. And then we have an emptying port and a little house that emptying port lives in. So I'm going to pass this around for you guys to take a look at. Now I'm going to be passing this around 3 times, I think, in this lesson. So I'm going to pass it around first just so you can look at it. And then a little while later today, I'm going to pass it around to talk about this port and how it works. Okay, so maybe twice. Here you go. So the catheter and the bag are two separate pieces. And the reason they're two separate pieces is because they're changed at different intervals. Catheters can be left in place for up to 30 days. So once we put a catheter in, we're going to leave it there for up to 30 days. The bags themselves have to be changed much more often, usually about once a week. So we don't want to change the catheter that often because that's when we run the risk of introducing bacteria. So catheters up to 30 days, bags more frequently, usually about once a week, but it depends on where do we go for information? Care plan. Care plan will tell us how often to change that bag. Good? Okay. So for CNAs, we clean and we inspect. We also empty the drainage bag and document the amount of output. You can be trained on changing that drainage bag. But as a brand new baby CNA, we clean the catheter, the skin around it. We take note of anything that we notice. Remember, observations are important, and we empty and document. We do not separate these two pieces without additional training. Doesn't seem very hard, right? You unplug and you plug. Not very hard. But the problem is when we unplug, we've now allowed an opportunity for bacteria to enter much closer to the patient.
What about if air got in that also?
Air's fine.
It won't cause like a clot in the, okay.
No, air is fine. Air does not impact this system at all.
Okay.
No. Not like you're thinking IVs, but yeah, does not affect the system at all.
Okay.
No. You guys remember this? We talked about this class too. Chain of infection. You guys remember that? We have a pathogen. That pathogen has to have a place to live, a way out, a way to get around, a way in to another host. That host must be susceptible, and then an infection can occur. Well, unfortunately, catheters provide a lot of these. So we have to be really, really careful when it comes to catheters. So urinary system review, we have two kidneys. We have ureters that come out of the kidneys. Urine comes down those ureters, drip, drip, drip into the bladder. That valve holds the urine in the bladder. What we're doing with the catheter here is we just put it in, we inflated that balloon, and that just keeps that bladder from filling up. Instead of the urine collecting in the bladder, it goes down the tube and out of the body. Good? That's all a catheter is. It's a diversion. We're diverting the urine into a bag. Because the urine flows freely, because the valve is held open, right? It has to be collected to some sort of a collection device, a bag of some sort. Now, if the patient has a catheter and we still see urine in the bed or the patient still gets wet, that means this catheter is not the right size. They're not one size fits all. Just like everything else, people come in different shapes and sizes. So if you notice the patient has a catheter, but you're still seeing wet, we need to let the nurse know because they probably need to go up a size on that catheter. Okay, it's not doing its job.
Is a catheter, sounds like a weird question, but for a female and a male, is it
Exactly
the same?
Exactly the same. The only difference is the length of the urethra. It's the same tube. And a lot of people don't realize this because, you know, the male and female anatomy visually looks different, but there are a lot of similarities there, right? We both pee through a urethra. So in women, the urethra is much shorter because it's mostly internal. Urethra on women is about as long as your pinky. From bladder to outside world, about as long as your pinky. Okay, this is why after childbirth, sometimes we can pee when we laugh or sneeze, because that's not a really long way, right? With pressure, something pushing down, a drip can come out. Got it? Make sense? Yeah, childbirth ruins your pelvic floor, guys. So pelvic physiotherapy for the win. All right, now male urethra, same tube. We still have a bladder. We still have a tube, but most of theirs is external, where most of our urethra is internal. Male urethras, most of it is external. So they still have the same amount internal. Okay, same amount inside their body. From bladder to like base of the penis is about that long. Okay, that's what they have is additional urethra through the penis, but all it is a longer urethra than you have. Exactly the same. So with males, we have to insert the tube just a little bit further to get to the bladder, but the anatomy, as far as the urethra goes, is exactly the same, just longer. Okay, theirs is external. The additional part of it is external, where we just kind of stick with the internal part. Okay, so there's no additional pain, and everybody thinks, oh my gosh, men, it's got to hurt more. Actually, no, because it's the same mechanism. Okay, now it could hurt more if they have an enlarged prostate, because now we've got a boulder that we have to route around. Okay, still same urethra. We're not drilling for anything, but we, kind of have to route around that enlargement. Okay, good, makes sense? Okay. So why does this matter? Well, if we allow pathogens to get into this bag, those pathogens aren't happy staying in the bag. The bag it's clear, so it's not dark. That urine is cooled down by the time they get there, so it's not real warm, but it is moist. So we have 1 out of 3. And it's got an all-you-can-eat buffet and an open bar. All the enzymes they need and proteins to procreate are here. It's missing a couple of the really big tourist attractions for bacteria, but it'll get the job done. So bacteria that get in here are going to procreate. Now, bacteria don't need little boy bacteria, little girl bacteria to have baby bacteria, right? There's no courtship process. All they need is the right conditions, the enzymes and the proteins, and they zip themselves in half, and now we got 2. 2 become 4. 8, 16, 32, 64, 128, 264, 512, 1064. And so, I mean, it just literally multiplies exponentially. So 1 bacteria in this bag in a very short time can become over 1,000. Well, this is going to get pretty crowded then, isn't it? So some of these little intrepid explorers are going to start climbing up that tubing because they see an exit. And they climb, and as they climb, now the urine's getting warm. So we're adding warm into the equation. Now they're really going to ramp up. And they're going to keep procreating as they climb and climb and climb and climb. And if they're lucky enough to get into the catheter, now we got rid of their light. Warm, dark, moist, all-you-can-eat buffet and open bar. Life is good for these bacteria. They're really going to start procreating like crazy, and they're going to keep climbing, and by the time they jump out of those holes into the bladder, there are trillions of them. This is why let me go back one. This is why catheters and bags are changed at different intervals. It takes a long time for a bacteria to make that journey. So if we change this bag out weekly, chances are any bacteria that's in here, we're going to get them before they get here. Okay, that's why bags need to be changed more often. But this is why you also have to be trained to change the bag. Because if you let bacteria in during that change, I don't know what's going on over there.
Sounds like you're pulling something.
Yeah. If you let bacteria into this catheter during that change, this is a day trip, guys. Day trip. No big deal. They'll do that all day long to get to the, prize at the end of the tunnel. Got it? Got it? So remember, the name of the game here is to not let bacteria in at all, because we know that this is the ideal environment for those bacteria. Absolutely. So what happens here is when this bladder just gets overrun with bacteria, right? They're always looking for an exit strategy, right? When it gets too crowded, like when town gets too crowded, you start looking for property in the suburbs, right? You're moving out. Too many people in here. I'm moving out, right? That's all they're doing here. So there's happens to be 2 beautiful roads right here, right? So they'll just, oh, I found a road. Let's go. Well, where do those roads end? In the kidneys. So that's how we end up with kidney infections. Now, the kidneys filter what? Blood. The kidneys filter blood. That means blood goes into these kidneys on a pretty regular basis, like nonstop. So do you think that those bacteria are going to confine themselves? They're always looking for an exit strategy when it gets too crowded. So what's the next step? Bloodstream. These patients can be septic because there's a direct relationship directly to the bloodstream. Make sense? It's way easier for a kidney infection to go septic, body-wide, systemic, than it is for a wound infection, because wound infections rarely have direct blood access, bloodstream access. Make sense? Okay. So there's 3 places, what we call the danger spots for catheter and bag assemblies. The first is down here. When we empty the bag, we have to be careful not to let any bacteria in, right? But if we do, not a huge issue, because it's a long way to go. We're the furthest away from the bladder. And we're going to change that bag out weekly. So chances are the bacteria is not going to be able to get somewhere that could make a difference. Got it? Least risk. Still a risk, but least risk. Now, here, where we change out the bag, a slightly elevated risk because we're closer to the bladder. And the bacteria that get here, we automatically give them the best chance of survival. Warm, dark, moist food, bar. Okay, so significantly higher risk. Here, when the nurse puts the catheter in, highest risk. Because we're pushing, if we contaminate that catheter when we put it in, we're pushing that bacteria directly into the bladder. Do not stop, pass go, do not collect $200. You're going straight into the bladder with that bacteria. So when we look at risk, CNAs empty the bag. CNAs can be trained to change the bag, but higher risk. CNAs do not insert catheters, highest risk. Good? Make sense? All right, bags need to be above the floor. They also need to be below the level of the hips. Because if you raise the bag above the level of the hip, whatever's in that tubing, it's like a water flume. It's going to go right back into the patient backwards. And all the bacteria that's in the way is going for a water ride right into the bladder. This is a huge risk for our patient, but it's also really high on my gross meter. Urine should be a one-way trip. Urine should not be put back into the body in any recycled manner. That's just gross. When you hold that bag up, that's exactly what you're doing. You're taking that urine and putting it back into the body in a recycled way. Now, I watch a lot of health shows, and I can't tell you how many times I've yelled at the TV. My husband hates it because they'll show a patient care tech or somebody walking a patient down a hallway holding the bag up like this, holding the urine bag up as they're walking. And yes, no, we don't. No, don't do that. That's recycled urine. Do you want even if it's yours, do you want recycled urine? No, don't do that. So bags always lower than the patient's hips, please. Okay. Gross. All right. This is the biggest risk, though, with catheters and tubing. If that tubing is not coiled on the bed, if it's hanging down, I'm going to pass this back around in a few minutes. If it's hanging down, right, people's feet can get tangled up in it. This is what happens because it's clear. You won't pay attention. It's clear. So feet will get tangled up into it. And when you're trying to untangle yourself, you'll pull that catheter right out. And it's not hard to pull a catheter out, guys. It is not hard. This is not a big balloon, right? The valve at the bottom of the bladder is kind of like my fingers. I mean, it has about that much strength to it. That's not much, guys. If I pull hard enough on this, it'll come right out. So with catheters, we want to be careful not to pull too hard because there's not much keeping it in there. Pull hard enough and it'll just slide right out. Well, this balloon is going through a space this big. You're going to get tissue tearing. There will be a little bit of blood. There will be urine, and there could even be a little mucus. Okay? Your patient is not going to be happy. Not at all. This stings. Now, imagine peeing through that. That's peeing razor blades. Mm-hmm. And it's going to take days for that to subside. Now, the real problem here, that's pretty bad though, isn't it? That's not even the real problem. The real problem is anytime that there is injury, there's swelling. Probably not a place we want swelling, guys. If I have to put another catheter in and the area is swollen, I may not have that opportunity. So I've only got about 45 minutes before the swelling is so severe that I won't get another catheter in. So if you pull a catheter out and you don't tell me, you hide it. You go on break. You leave it for the next shift to find because you don't want the lecture. Do you know who's going to pay the price for that? The patient. That's right. That's right. If a catheter gets pulled out, tell the nurse. Don't hide it. If you get the lecture, you deserve the lecture. Be an adult. It's a learning opportunity, right? Right? You'll only do that once, but you probably will do that once. Don't hide it. Now, we're not the only ones that pull catheters out, though. My patients pull them out. But usually when a patient starts pulling on it and it hurts, they stop. Not always, especially if they have dementia. Dementia will absolutely pull this thing out, no problem. Again, if we find the catheter in the bed, what do? We tell the nurse, absolutely. If you catch a patient pulling on the catheter, what should you do? Tell the nurse. We want to try to prevent that problem from occurring, okay? So the way that these go together, we have a bag, we have a catheter. This port matches up with this one, but it's snug. So I put this port inside the hole and I push it on and keep pushing and keep pushing and keep pushing until I'm sure that I can't push any further. Okay, and that's how these come together. Now I can pull pretty tight on that and it's not going to go anywhere. It grips pretty hard. But if you just barely put it on there and you pull, it's going to separate. So you really want to make sure that when you're trained to do this, that you put it on as far as you can and then you keep trying to get it as far on there as you can so that when the patient turns over in bed and it tugs on it a little bit, it doesn't dislodge it. Okay. So I'll pass that around so you can see how those, you can try to pull it apart and put it back together. That's fine. Remember, you have to be trained to do that. Okay. This is not training for that. All right. So sometimes patients pull it out, let the nurse know. But if you find a catheter, either you pulled it out, the patient pulled it out, you just saw it on the bed or on the floor, what do you do with it? Well, you don't throw it away in the traditional sense. Okay. We're not just going to find a trash bag and dump it in. What we're going to do is get an empty trash bag from the bottom of your trash can. All trash cans have empty bags at the bottom of the can. You're going to grab an empty bag out. You're going to put the whole thing in that empty bag. The catheter, the bag, the whole thing. You're going to put that in the patient's bathroom, and then you're going to go let the nurse know, hey, patient's catheter came out. It's in a bag in the bathroom. I have to look at it. Because sometimes when a catheter gets pulled out, that bubble gets burst. And just from the pressure. And if the bubble burst, I have to make sure that no pieces of it got left behind in the patient. The only way for me to find that out is to look at the catheter itself. Does that make sense? If you tell me, hey, a catheter came out, I threw it away, I don't know where it's at now. Is there something left in the patient? I don't know. So now we're doing temperatures every 4 hours or every 2 hours around the clock because I'm trying to see the body may have a foreign object reaction to that, and it can cause an infection in the patient. So we need to know what we're dealing with. So if a catheter comes out, we simply put it in a clean trash bag in the patient's bathroom for the nurse to be able to review. Good? Good. All right, there's a couple different kinds of catheters. This is the one we've been talking about so far. This is called a Foley cath. Remember I said everything in healthcare has 2 names? Catheters have 3. So this is an indwelling catheter, a Foley catheter, and it's also called a, oh geez, my brain just died. Hold on. Indwelling. It's mostly called a Foley. That's what most places call it, is a Foley catheter. It's got another name, but it's not. It's escaping me at the moment. This is called an intermittent catheter. Now, an intermittent catheter means I'm not leaving it in place. Remember, the whole reason for the bubble was to keep it in place like a little doorstop, right? This one, I'm just putting in to get urine and taking right back out. I'm not leaving it. I'm just emptying the bladder once with this. Okay, so we put it in, no balloon. Hold it there and take it out when we're done. Short term, 2 minutes. It's also called a Red Robinson cath, and its other name is a straight cath because there's no bubble. Okay.
Why would they use one like that instead?
So if we have a patient who went through surgery and has not peed after we took their catheter out, and we waited, and it's now been 8 hours. We've been pushing fluids and nothing has come out. Well, that's a problem. So I need to find out how much urine is actually in there. How much are you retaining? Well, I don't want to put another stay-in catheter because the whole point is we're trying to get your body back up and running normally. So I'm going to pull a let's empty the bladder catheter out.
Okay.
We're going to put this in, empty the bladder, measure it to see how much you're retaining. And I'm taking that out because I want your body to get used to peeing again, right? With a catheter, you're not going to have that. So this is a short, quick, empty, and be done. We also will use this a lot of times with children when we need a urine sample if the child is not potty trained yet. Okay, it's a very common use for this. Yeah. All right, because you can't pull urine out of a diaper. We also have little bags that are adhesive that we can put there to collect urine. But if we need it like now, can't wait. Straight cath it is. Depending on how tiny the baby is, we're not using a catheter that size, guys. We're using one that's like the size of a pencil lead. I mean, it's super small. Okay. So we also have a third type of catheter. This is a male catheter. This thing has a ton of names. Texas cath, condom cath, external cath, male cath. Ton of names here. Its technical term is a condom cath because it goes on just like a condom. Okay, it goes over the shaft of the penis. You have that same tip that we have. Okay, and that will allow that bag to plug right into there, just like on the catheter, the indwelling catheter. Okay, these, same thing. These, when they're put on, are generally left on up to 3 days. Now, the nice thing about condom caths or male caths is that we aren't invasive. We're not putting anything into the body. The urine is coming out normally. It's just being diverted into a bag. Okay, make sense? So there's less infection risk. The problem with this, and it is a big problem, these are not used without some thought to it, okay? You would kind of have to think this through. They're good in certain situations, but the problem is that this is a reservoir tip, right? So the end of the tip of the penis is going to stop right about here when you put it on. So you've got this little section right here that is going to hold urine right up against the tip of the penis. Urine is acidic. Urine is likely to eat skin, especially over 3 days. This is very thin, sensitive skin with high blood flow, which means that you can end up with sores in this area if we don't take really good care of the skin. So that's why we have to take this off every 3 days. Do very good peri-care, male peri-care, very good. And in most cases, when we have this, we use something called skin prep, which looks like an alcohol pad, and you wipe it on the skin and it provides a protective barrier. It just, kind of like nail polish. You know how nail polish, when you put it on your fingers, is an extra layer, right? This is a skin prep. You can't see it. It's not like nail polish, it's not real thick, but it provides a layer over the skin to help prevent that acidic urine from coming into direct contact with the skin. So if you're going to be changing this, make sure you understand the instructions on the care plan. Are we using skin prep or are we not? Good?
And then you have this special training to be able to change that one anyways. As
Right,
well.
right. You would have to be trained on how to do that. Good? So you guys all understand catheters? Don't hold them up. Don't let them touch the floor. If they fall out in any way, put them in a bag in the bathroom for the nurse to see and let the nurse know. If the patient complains, we let the nurse know.
Now,
Good?
On this thing, it's showing where you're holding it, like right there at the opening. So you got to be careful as far as holding it to not pull. Like any movement at all could pull it out, right?
No, let me show you. Not any movement. We are going to be careful, yes. I mean, you are right with that, but put your hand out like this. Open your fingers a little bit. Okay.
Right.
Okay. I can pull.
Okay. Right.
Right? Because you've got about, maybe not quite, I think but you've got, quite a bit of tension there.
Right.
Okay.
Okay.
It's not as easy as plop, right? So what we want to do is try, but that stretch is going to hurt. I mean, it's still, there's some nerve endings there. They're still going to feel it if we pull too hard. That's exactly why we hold it here. So it's not pulling on the inside. Okay.
Right.
So if I hold it here, where it's exited the body and I pull, I'm only pulling this part, not what's inside the patient. Okay. Good question. So we're going to do peri-care, middle, side, skin fold, holding that tube out of the way. We just want it out of the way for a minute. Then when, after we've done peri-care, middle, side, skin fold, wash, rinse, dry, then we're going to hold the catheter where it exits the body and wipe down the catheter away from the body. Doesn't matter whether this is male or female, the tube is cleaned the same. Male peri-care, we hold the shaft of the penis. We start at the top, move in a circular motion down the shaft, wash, rinse, dry. Okay. Your skills book talks about that. We're going to use the same cleaning methods, our leaves method. So we're going to wipe once, fold the leaf, wipe again, fold the leaf, wipe again, fold the leaf, wipe 4 times. Whatever we wash, we rinse. Whatever rinse, we dry. Good. Not much there. Questions? Okay, so Provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Now, the reason they're having us do this on a female resident for the test is because the infection risk is higher. The urethra is shorter. That's not far for a pathogen to travel. Males still have a risk, but it's less than a risk. We're going to use all of these principles that we already know, but let's go over our skill-specific steps now that we understand what a catheter is and how they're used. So we're going to put a chucks under our patient to keep the bed dry while we're doing all this cleaning. We're going to hold the catheter out of the way while we clean the peri area using peri-care techniques. Whatever we wash, we rinse. Whatever we rinse, we dry. Okay? Remember, top to bottom, never go back up. Wash, rinse, dry. Now we're going to hold the tubing where it exits the body, wrap our washcloth around the tubing, and wipe away from the body 4 times. Whatever we wash, we rinse. Whatever we rinse, we dry. But you definitely want to make sure you're holding that catheter where it exits the body so we're not pulling on the inside. And then we're going to take that chucks out from under the patient. We don't need it anymore. Good? Good. Make sure that bag is not hanging near the floor. Make sure that the tubing is coiled on the bed and not near the floor where people's feet can get all tangled up in it. So let's see how we would check off our checklist for this. We're going to follow our care plan. We're going to do our opening. We're definitely going to need gloves. We're personal skin, body fluids. We're going to use a barrier to put all of our stuff on. We're going to need a privacy blanket for this because our patient is uncovered and undressed. We're going to keep our patient in the middle of the bed. We're going to use our washing rules. We're going to clean our basin like we clean everything else and do the skill-specific steps. But guys, there aren't very many skill-specific steps on this one. And half of them we already know. And then we're going to follow up with our closing. Okay? This care plan is only for this patient. Nobody else, just this one. But I'm not going to show you the video for this right now. Instead, I want to roll into drainage bag and talk about that really quickly. And then I'll show you these 2 videos back to back. Those of you who are going to have to leave, that way all you'll have to do is watch those videos to get caught up, okay? All right, page 165 gives us our step-by-step instructions, care plan at the top, supplies at the bottom. Here's our care plan. Empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. So for this skill, we're going to empty the bag into this container. We're going to measure whatever came out of the bag, and we're going to document it. That's the skill. Very little to do with the patient other than your opening and your closing. Okay? But there's a couple different kinds of bags. Just like there were a couple different kinds of catheters, there's a couple different kinds of bags. So this is the one that I passed around earlier. This is a bedside bag. Holds a lot of urine. We use it in a clinical setting. But if the patient's at Walmart walking around, they do not want to carry a suitcase of urine with them. People will stare. It's uncomfortable. So in that case, the patient might need something that's a little more mobile friendly. And that's where a leg bag comes in. Leg bags connect to the catheters just like bedside bags connect to the catheters. No difference. The only difference is it's smaller and could be attached to the inside of the thigh or the calf and covered with clothing. Self-contained. People are walking around Walmart right now with a catheter and you have no idea it's there. No clue. Now, these patients are usually able to empty them themselves. They'll go into the bathroom just like you would go into the bathroom, but instead of using the toilet like you would, they would simply position this port over the toilet. It's a screw top, so they just unscrew it, and the urine empties from the bag into the toilet. They close it up, and they're ready to go again. Okay?
How come they wouldn't use those as well for like regular when you're like in the nursing homes and stuff?
Because there's 2 reasons, okay? First, they don't hold nearly as much. Okay, so you would be, as a CNA, you'd be emptying this thing all the time. No need for that. But the other is because of gravity on planet Earth. Okay, when you're upright, this works fine. Gravity is pulling that urine down. When you're laying in bed, if we had the bag on the body in the bed, that gravity isn't going to put the urine in the bag. It's actually going to let the urine go back up into the body. So we want something that is dependent or below the bladder. Great question. Okay, so when the patient is in bed or more sedentary, we use the bigger bag. If the patient is up and mobile, we generally use the leg bag. Okay. They both attach to the same port on the catheter. And a lot of times your patients, especially if you work in home care, those of you who go into home care, your patient will have a leg bag when they're up and during the day, and they'll have a bedside bag when they're in bed asleep. So your patients may actually use both depending on the time of day. Now, when it comes to these bags, what you need to know is how to empty them, because that is a CNA task. So right here on the bag itself is an emptying port. Emptying port. It has a little house that it lives in. There's a couple of different types of ports. This is the bag that we're using and the one that's used for the test most often. This is an older style bag, but it still may be used in different settings. It has a clamp. So it's literally a clamp that you click and unclick. It's a clamp. And then there's the twist valve, which we saw with the leg bags. Okay. CNAs are going to learn how to empty the bag. You can be learned how to change the bag with additional training. Do not disconnect a catheter from a drainage bag without being trained. The reason that I keep going over this and over this and over this and over this is because during the test, a lot of students during the exam will disconnect the catheter in the bag and take the bag to the bathroom to empty it. Are we allowed to do that? No, we do not disconnect the catheter from the bag. Does that make sense? But unfortunately, a lot of people do that in the exam. We don't do that. That's why I keep saying you have to have additional training for that. And that's not good. I don't ever do, even with additional training. You separate them just long enough to put a new bag on. Okay, we don't take the bag to the bathroom. All right, so we have this port in its little house. Okay, what we're going to do is take it out of its house, open it, and empty the contents of the bag into the container. Now, we don't want the container on the floor directly. What's the only thing that can go on the floor? Yeah, or shoes. Yeah, shoes and a barrier. Yep, that's it. So we need to put a barrier on the floor and put our cup on the barrier before we empty that bag. Make sense? Good? Okay. Once we've emptied the bag, we need to return that port to its house without touching anything. So this is my port. If bacteria is going to get into this bag, it's going to be through here. So when we remove this thing from its house, it cannot touch anything. Can't touch my gloves, the cup, the floor, the barrier, the bed, the bag, or anything else. It gets removed from its house, opened, emptied, closed, and tucked back up into the house without touching anything. Do you guys see how I put it right back into the house without letting it touch anything? And I can't even see it. Okay. You have no excuse. Okay. Good? Yeah. And leave it closed so I can show how to work the T-valve. Okay. So if you look inside there, can you see through there? See how it's open? I'm going the wrong way. There we go. See how it's open? If I do this, now it's closed. See how it's closed inside? See how it's closed? Okay, so when you're getting ready to open it, we're going to keep our hands below that port. I don't want to be up here. This would make it way easier for me to open it. I have more leverage. But if I put my finger up here, this is where bacteria are going to enter. So we never put our finger near this port. We stay behind the T. Make sense? So in order to open it, my fingers stay back here and I open. To close, my fingers stay back here and I close. Now to put it back in its house, you simply slide it up into its house without doing this. Good? Okay. You guys can play with the valve. All right, so when we empty the drainage bag, we're going to place the graduate container on a barrier on the floor. We're not going to let that drainage port touch anything, nothing. And then we empty the contents into the container. So when we empty the bag, it's going to put the urine in the container on the barrier. When we're ready to measure, we need to measure this on a barrier, on a flat surface, and at eye level. So I can't measure this when it's on the floor because I am not at eye level. So I'm not measuring this when it's on the floor by the patient. I'm going to take this whole thing, the barrier wrapped around the container to the bathroom to measure it. And I'm going to make sure it's on a barrier, on a flat surface, and at eye level. I'm going to round to the nearest line so we can see that this urine in this cup stops at 450. For medicine, we always use cc's and mLs. You guys remember that? So we don't even pay attention to this side. This is at the 450 line, so I would consider this 450 mLs. I'm not going to say 451. Round to the nearest line. Each one of these lines is 25. So this is the line for 250. It's marked. That's 275, 300, 325, 350, 375, 400. Good? If it were closer to this line, it would be 425. If it were halfway in between, pick one. Okay? Which one is it closer to? Good? Good. Okay. And we have to document this. Anything we measure, we have to document. So this is the intake and output sheet. This is on page 169 of your book. But this is what we're going to document on. Down here under output is where you want to document this. If you put it in the intake section, you are saying that this patient drank urine. So output, make sure you're putting it in the right place. All right, so we're going to empty the resident's urinary drainage bag into a graduate container, measure and record the output in mLs or cc's on the documentation form. So the steps for this is we're going to protect the floor with the chucks. We're going to empty the bag, not letting that port touch anything. Protect that port. We're going to put it back into its house without letting it touch anything. Now you're going to, if you go look at any of my old videos or even my new ones, people are commenting on it. A lot of people are going to tell you to wipe this off with alcohol before you put it away. And that's something we used to do. And a lot of people are still teaching that method. But I want you to pay attention to the actual checklist. Never take my word for it. Go by the checklist. And that's why I always post these for you. This is the actual checklist that Prometric uses when they grade you. There is nothing on there about cleaning it with alcohol. It is not a graded checkpoint. We learned, because medicine is always evolving, we're learning new ways of doing things. If we didn't learn new ways of doing things, you guys would still be using leeches when you got a common cold. Okay? Medicine evolves. And what we learned was that the plastic of this port, the material it's made out of, when you put alcohol on it, it becomes very brittle and microcracks form, which is the ideal harboring place for bacteria because it's warm, dark, moist, and hidden. So we found that by cleaning it with alcohol, it actually made it much more susceptible to bacterial colonization. So that is no longer a recommended action. Okay, and it's reflected in our checkpoint. It does not have us cleaning the port with alcohol. Now, that doesn't mean that your facility policies and procedures might say clean the port with alcohol. You're going to follow your facility's protocols. They're the ones signing your check. You're going to do what they are telling you to do. Okay, because maybe their patient population, that is an acceptable risk for them. Make sense? Good? All right. We always cover any container of urine or feces. We don't walk through a room with an open container of urine. Take it to the bathroom. We're going to put it on the lid of the toilet, unwrap it. It is on a barrier, on a flat surface, and I'm down at eye level. Do not hold this thing over your, never hold urine over your face. On a barrier, on a flat surface, and I am down at eye level. I'm going to empty that container into the toilet. I'm going to rinse it, dry it, and store it like I rinse, dry, and store everything else. I'm going to check to make sure the tubing is not coiled near the floor and the bag is not near the floor. And I'm going to do my closing and document in the output section. Good? Let's see how we're going to check all this off. This is our checklist. We're going to do our opening or read our care plan, do our opening. We're going to wear gloves because it's urine. We need a barrier on the floor. We're going to clean our basin the way we clean everything else. And we're going to do our skills-specific steps, following up with the closing at the end. This care plan is only for this patient, nobody else. Every care plan will be different. Good? Good. All right, Jake's going to show you these two videos back to back. Now, I want you to remember that catheter care we had 15 minutes for. And this skill, I think it's 9 minutes that they give you. Is it 9? Okay. These two videos do not take that long. I do catheter care, and I think it's like 7 minutes. And this skill takes me like 5. So the videos aren't that long, okay? Don't rush this, but these are things that you don't have at home. Most of the other skills you can kind of get away with making do at home, right? You can use a Tupperware container for a wash basin and do hand and nail care on somebody at home. You can make do, you can use a belt as a gate belt. You can kind of make do with things you have around the house. This is one skill where you really don't have that opportunity because you don't have one of these at home. You don't have a catheter or a bag at home. You can't really get used to that T-valve, how it works. These are skills, everything that we talked about today are skills that you probably want to make sure you're practicing here in the classroom, or you get a practice kit to practice with. Now, the practice kit has the bag. It has this. It has the bedpan. It does not have a catheter in it because I can't trust that students won't try to put a catheter into somebody, okay? So because it's invasive, I do not include a catheter, but you could tape a straw to it to simulate. Get creative. I'm going to pass this around so you can take a look at it as we watch the videos.
Would you prefer,
Catheter care first, please. Good afternoon, Mrs. Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I'd like to perform catheter care. Is that okay? Okay, I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, we're going to need one underpad. We're going to need a towel, 4 washcloths, 1, 2, 3, 4. We're going to need a privacy blanket. We'll bring this over to the patient area. And I'm going to need a basin and soap. And a set of gloves. All right, Miss Jones, I'm just going to fill your basin. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about 1/4 of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. Okay. I'm going to place this privacy blanket over you, and this is going to help keep you warm and provide privacy as we do this skill. So I'll lay the privacy blanket over the sheet without snapping it or shaking it, and then pull the sheet down to about your waist. I'll put the washcloths in the basin. That way they get warm. And I'm going to prepare the underpad to go under the patient. I'll open it up. I'm going to hold it up lengthwise with the absorbent side facing me, and I'll roll it all the way to the end. Now I can put my gloves on. Okay, Miss Jones, we're going to place an underpad under you to keep your sheets dry while we do this skill. So I'm going to place an underpad on the bed. And in just a moment, I'm going to ask you to scoot toward me. I'm going to roll you on your side, and then we'll spread that underpad out. So on the count of 3, go ahead and scoot toward me. 1, 2, 3. Thank you. And now I'm going to roll you on your side. 1, 2, 3. And as I roll the patient, I want to be careful not to put any stress on this catheter or the tubing. You don't want it pulling tight. So I'm going to unroll the chucks underneath the patient and tuck it under her hip. Miss Jones, come on back and scoot to the middle of the bed, please. Okay, Miss Jones, we're going to repeat the process. Go ahead and scoot toward me. And we're going to roll you onto your left side. 1, 2, 3. And I'll smooth that chucks out underneath the patient. Come on back onto your back. And then scoot to the middle. Now we can begin the cleaning. Miss Jones, I'm going to expose you. I'll make this as brief as possible. But please let me know if you're uncomfortable in any way. I'm going to roll the privacy blanket, making sure that I get the gown inside the blanket as I roll it. But I don't want to grab that catheter as I'm rolling the blanket. So you want to be very gentle with this process. This is going to expose the peri area. And then I'll place a towel over the upper thighs and make sure that the catheter tubing is on the towel. This is to help minimize exposure, increase comfort, and gives a place to put the catheter while we're cleaning it. Now I'm ready to start cleaning. I'm going to take my first washcloth, wring it out, and I'm going to soap 5 corners. 1, 2, 3, 4, 5. I'm going to hold the catheter out of the way, retract her labia, and then wipe down the center, top to bottom, and then move away and fold that leaf. The second leaf will wash the outside of the labia, top to bottom. We'll fold that leaf over. This is going in one direction only, top to bottom. This third leaf is going to wash the other side of the labia, top to bottom. We'll fold that over. The fourth leaf will wash the skin fold between the leg and the groin, top to bottom. We'll fold that over. The last leaf will wash the skin fold on this side, top to bottom. Now we'll set that aside on the barrier. And whatever we wash, we rinse. So we're going to wring that washcloth out really well. Hold it using the leaves method. I'll hold the catheter out of the way and open the labia and rinse down the center one direction, top to bottom. We'll fold that over. We'll rinse the outside of the labia, top to bottom, fold that over. The other outside of the labia, top to bottom, fold that over. This is going to rinse the skin fold. Fold that over, rinse the skin fold. We'll set that aside. Now we're going to clean the tubing. So I'll get washcloth number 3, wring it out really well, hold it using the leaves method, and I'm going to soak 4 leaves. 1, 2, 3, 4. I'm going to hold the catheter where it exits the body so it doesn't pull on the inside. Wrap the washcloth around the catheter and wipe away from the body. We're going to fold that over and repeat 3 times. Hold the catheter, wipe the washcloth around, and move away from the body. 2, 3, changing the leaf for each stroke, and 4. We'll set this aside. Whatever we wash, we rinse. I'm going to wring the rinsing washcloth out thoroughly, hold it in the diamond shape in my hands, hold the catheter where it exits the body, wipe the washcloth around, and rinse going down the catheter. We'll fold that leaf, rinse 2, fold that leaf, rinse 3, fold that leaf, and rinse 4. We'll set that aside. Whatever we rinse, we dry. So we'll dry the peri area top to bottom and the catheter tubing. We can remove the towel, set it on the table, and we're going to unroll the privacy blanket, trying to be careful not to touch that gown with your soiled gloves, and we'll cover the patient up. Mrs. Jones, can I get you to scoot toward me, and I'm going to remove the pad that's under you. Go ahead and scoot toward me, and on the count of 3, you're going to roll up. 1, 2, 3. I will roll the soiled chucks toward the patient and tuck it underneath her hip. Come on back, Miss Jones. When I'm moving Mrs. Jones, because my gloves are soiled, I'm only touching the outside of the privacy blanket. Mrs. Jones, scoot to the middle of the bed, please. And now we can remove your chucks. If you can scoot toward me, again, my soiled gloves are only going to touch the outside of the blanket. And then you're going to roll up on your side, 1, 2, 3. And I'll remove that chucks from under the patient. Come on back onto your back. And then if you can scoot to the middle. Thank you. I'm going to go dispose of this. Okay, Mrs. Jones, you're covered. You're safely in the middle of the bed. I'm going to go dispose of your linens and clean your basin. I'll be right back. These items will go in dirty linen. We're going to clean this basin the way we clean all basins. I'll bring the basin to the sink and we'll dispose of the water in the sink. Rinse the basin and then dispose of the rinsed water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. Now we can dispose of the barrier. This will go in the garbage. And I can remove my gloves. Okay, Ms. Jones, I'm going to remove your privacy blanket now. I want to check your tubing real quick just to make sure that it's not kinked and you're not lying on it. So it looks good. It's not near the floor. So I'll pull the sheet up over the privacy blanket. This ensures that you're always covered. And I'll remove the blanket as I do so. I want to make sure that the blanket is rolled into a ball so trailing edges don't contaminate other surfaces. We'll make sure that the sheet looks good. All right, Ms. Jones, just let me go dispose of this in dirty linen. I'll be right back. We'll adjust the sheet on this side. There you go. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your bed is in the low position. Your environment is clean. Here's your call light. If you need anything at all, go ahead and press the red button. We'll be happy to come help. I'm going to open your curtain and return your overbed table to storage. Now I'll go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Good evening, Mrs. Jones. How are you today? Fantastic. I need to empty your urinary drainage bag. Is that okay? I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get my supplies. We're going to start with the chucks. This is going to go on the floor under the bag. We're going to place the barrier on the floor directly under the urinary drainage bag. So we'll unfold it and we'll place it under the bag with the absorbent side facing up. I'm going to go get a set of gloves. And we're going to get the graduate container out of the drawer. You need to make sure that you put your gloves on before you get the graduate container. We're going to place the container on the barrier directly underneath the bag. We use the emptying port to empty the bag. This is a T-valve. We slide it to the side to open the valve, and then we're going to empty the urine into the graduate container without letting that port touch anything. Once the bag is empty, we'll close the port and place it back in its little house. All right, Ms. Jones, I just want to check to make sure the tubing is coiled on the bed and you're not lying on it, and that it's not coiled near the floor either, where it could become a tripping hazard. Now, I can wrap the chucks around my graduate container for safe and secure transport to the bathroom. We're going to set it down on the lid of the bedside commode and unwrap it, turning the cup around so that we can read the amount of urine that's in the cup. We need to be at eye level. It needs to be on a flat surface and on a barrier. I'm going to throw the chucks away. Open the lid and the seat and dispose of the urine into the bedside commode. I'll rinse the cup and dispose of the rinse water into the bedside commode as well. We'll close that, set the graduate container down in the sink, and disinfect it per facility policy. I'll pick it up with a paper towel, dry the inside with a paper towel, throw that away, dry the outside with a paper towel, throw that away, and one more for the drawer. Okay, Miss Jones, I'm just going to return this to storage using a paper towel to open the drawer. And closing the drawer, we'll throw those paper towels away, and then I can remove my gloves. You take a peek at your tubing just one last time. Everything looks good. Are you comfortable, Mrs. Jones? Is there anything else I can get for you while I'm here? No? Would you like a magazine before I go? Your bed is in a low position. Your environment is clean. I'm going to open the curtain. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come back and assist you. Thank you very much. I'm going to go wash my hands. After washing my hands, we'll document the amount of output on the documentation sheet provided by the evaluator. We're going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. And we want to make sure that we're documenting in the output section. After documenting, I'll wash my hands one final time. After washing my hands a final time, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. Okay. Any questions? No? Congratulations, you have made it through all the skills. There is nothing else I need to teach you for skills. Now it's just practice. Practice makes perfect. Okay? Remember that you have next week, Monday and Wednesday, that you can come in and practice. If you need the sign-up sheet, let us know, and I'll get that out for you. Sure.
On the state exam, I can't remember, you may have told us already, like how in our book down here, how it shows us what we're going to need for our supplies.
They do not tell you.
It does not. So
No.
you have
to know your supplies. And the reason is, remember that the test is nothing more than an audition to say I'm ready to work. That's all the test is. So when you go into the test, if I tell you, hey, go empty that drainage bag, I'm not going to tell you you need a set of gloves, a barrier, a graduate container, your documentation sheet, and a pen. I'm going to expect that you know what you need to do that job. So I'm going to just say, go empty the drainage bag. When you're looking at the test, I want you to look at it not as, oh my gosh, I'm being tested. I want you to look at it as an audition to say, I'm ready for work. I got this. Let me show you that I'm ready to work. And if they agree, they'll give you your certification that says, yes, we agree, you're ready to work. And then you can go to work. Okay. But instead of thinking it as, oh my gosh, I'm being judged by how well I do these things, it's more, I'm ready, I just need to show them. Okay. And if you're not ready to go to work, you're not ready for the test. Because what is on the other side of the test? Work. That's the whole reason you're going through this, right? You're not just trying to get some initials behind your name. You're trying to get a job as that thing, as a CNA. And everybody kind of stops at the test, right? I got to get through the test. But the next day after the test is work. This is where it really counts. And that's all you're telling them is, hey, I want to get to there. Let me show you I'm ready. And the bar, guys, is ridiculously low. Ridiculously low. Entry level standards. That's what they're testing you on. Entry level. Kindergarten standards. What you're saying is, I promise not to kill everybody while I'm learning how to perfect my skills. That's really what this is about. Making sure the patient is sitting up when you're brushing their teeth. That might be important. Make sure you're not feeding them too fast so you don't choke them. That might be important. Making sure you don't give them a UTI when you're cleaning them up. That might be important, right? Those are the things that we're looking at some other things too, but those are the main things that we're judging on is this person safe? Not how well can they walk a patient 10 steps, right? It's not the walking, it's can you keep them safe? Okay. And yourself safe too, right? Body mechanics is going to count. Good? Does that make sense? If you are not coming in here to practice, if you're not staying to practice today and Wednesday, if you're not coming back next week to practice, this is your friend. And right now they're $49, is it $49.99, I think? Yeah. And after Wednesday, after class on Wednesday, these go up. I think I've got them online for like $75. So you're getting a significant discount if you buy them before class is over on Wednesday. So if you're coming in here to practice, that's awesome. I've got everything in here for you. Practice in here. But if you're going to be practicing at home, you might want to consider this. Homework for tonight, last chapter, chapter 10. It's all on employability, stress management, that kind of thing. I'm going to be going over a lot of this in class on Wednesday, but you probably should still read the chapter. It's a short one. It's an easy one. Okay. You will get, no, you will not. Let me back up. I'm having email server issues, guys. Anybody that's watching on there, if you're emailing me, I've got a million emails right now about the course. I know I've got email server issues. As soon as I'm done here, I'm racing home to try to fix the web. I do the websites, guys. That's all me. I had to learn how to code to do all this. There's days I need to raise my prices so I can afford to hire people. But I got to go home and fix this. So no, you will not get an after class wrap up email today. But you guys know where to find the live stream, right? flcnatraining.com. It's there. All of my skills videos, there's a link there for all the skills videos. Go to flcnatraining.com. You will not get an email from me today because my email server is down. Websites are still up. They're just slow. Websites are up, but my email is completely down right now. Okay. I'm working on it. Be patient with me. All right. On Wednesday, you need to bring that book back. Please make sure you're bringing your yellow book back. I will give you a graduation folder if you give me that book back. Okay. All right, CPR class we've already talked about, and Jake passed out your review sheet for you. Remember, tomorrow, 11 a.m. is the game show. It might be a really good idea for you to, if you can't attend, at least watch the replay. Put me on double speed, that's fine. But watch the replay of it, because it'll give you an idea of the types of questions that you're going to have on the state exam, how they're going to be structured, how the answers are going to be, how to figure out what the right answer is. Now, in your skills book on page 192, 191, might be 191. There is a full practice test, 60 questions, multiple choice, just like the state exam. This is your dress rehearsal. What's that?
I already started doing
Okay. Yep, this is your dress rehearsal. If you miss 5 or fewer on this practice test, you're ready for the state exam, the written part. If you miss more than 5, you need to see me on Wednesday, and we're going to figure out why. Okay. My students usually do very, very good on the written tests because I've kind of trained you throughout this entire program what they're looking for. So you usually do really, really well on the practice test. Remember, we follow the care plan. We use all of the principles that we've learned on how to do the skill. When we communicate with dementia, we redirect. With everybody else, we use respect, empathy, acknowledgement, and discretion. With theory, everything that we read, we just remember what we read, all the things I've told you in class that are important, like sit the patient up for mouth care, right? Those types of things. And safety always comes first. Safety comes before notifying the nurse. Get the patient safe first before we notify the nurse. Never leave a patient alone in distress. That's what you need to know about safety. Every safety question, one of those 2 things. Easy. Okay. And then if it's a change, if it's something you notice, what do we do with it? Report it to the nurse. Do we ever change a care plan? All right. You now know everything you need to know to take the written test. Every question will meet one of those 6 things. Apply the rule that I just gave you, and you will automatically get the right answer. Okay. Good. Good. All right, I'm going to open it up for practice. Let me sign off of online, and then you guys are able to stay in practice. Those of you that joined us today, thank you so much for tuning in. We truly appreciate it. We hope to see you tomorrow for the game show. Wednesday is graduation, but you want to tune in on Wednesday because I'm going to give you a foolproof way of answering. Tell me a little bit about yourself. You know that question in the interview that nobody knows how to answer? I'm going to tell you how to answer it specifically for you, that you're going to ace that interview. So tune in on Wednesday to find out how to do that. Until next time, happy caregiving. Bye.